Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. This is Carmen Boone, Education Coordinator from Oregon Pacific Area Health Education Center. Thanks for joining us today for our webinar. Today, I will be your host and moderator. Let's go over some housekeeping items. All microphones are muted. If you are experiencing audio difficulties, make sure your computer speaker volume is turned up or use the phone option to listen in. Slides can be downloaded down from the handouts panel. We will also email them to you by the end of next week. Please use the questions panel to ask questions and submit comments at any time. Questions will be answered at the end. If we run out of time, we will still answer your questions via email. We will email you the Q&A by the end of next week. This webinar is being recorded and will be available by the end of next week at the address that you see on your screens. If you have any questions, please email me at carmenb@samhealth.org. This webinar is produced by the Oregon Pacific Area Health Education Center, a hosted agency of Samaritan Lebanon Community Hospital, and it's presented by Dr. Robert Walker. Robert Walker is a board-certified pediatrician with over 30 years of experience in clinical practice and biopharma. He is currently Senior Medical Director at Dynavax Technologies and leads the Medical Affairs Department. He has over 13 years experience in vaccines at several companies, including MedImmune and AstraZeneca. In addition, he is a certified physician executive with the American College of Physician Executives. Now, without further ado, I will leave you with Dr. Robert Walker.
Good, thank you, Carmen, and thanks everybody for joining the webinar. Just want to adjust the screen a little bit. There we go. Good. I'm coming to you from Raleigh, North Carolina, but I have been to Oregon. Love it out there, and I hope everybody out there is staying safe because we are living in some crazy times right now. A little bit about myself. I do want to mention that I'm an employee of Dynavax Technologies. Dynavax Technologies manufactures Hepatitis B, which is the 2-dose vaccine mentioned in the presentation. This is not a promotional talk, it's an educational talk, but I am going to be mentioning the 2-dose vaccine a little bit later in the presentation. I'm going to give you a lot of information about hepatitis B. It's kind of like everything you ever wanted to know. So I'm going to talk about the clinical background and epidemiology of hepatitis B. We're going to talk about serology and management, because that's one of the biggest challenges with hepatitis B is, what do you do with all these tests when you get them back? We're going to talk about vaccines in general, just what's the science behind vaccines, and we're going to talk specifically about hepatitis B vaccines and what are your options out there, sharing some of the latest data. So first of all, we'll just move right into hepatitis B. And what you see here is actually an artist's rendering of a virus, a hepatitis B virus, and what all viruses have in common is that they're a unit of genetic material, either RNA or DNA, and that genetic material is typically in the core, and it is surrounded by a membrane, which includes lipids, and then there's surface proteins on the outside. And I'm going to be talking about surface antigens a little bit later. We're talking about some of the antigens that are on the surface of the virus. When we talk about hepatitis, we talk a little bit about the alphabet soup, hepatitis A, B, C, D, and E. But one of the things that's really unique about hepatitis B, it is the only DNA hepatitis virus. All the rest of the virus, of hepatitis viruses, A, C, D, and E, are RNA viruses. But what they all have in common is they infect the liver. And that's why hepatitis is inflammation of the liver. And when someone gets hepatitis B, it can either be an acute infection or a chronic infection. And an acute infection can be up to 6 months. Some people are actually asymptomatic. They don't even know they have anything, and it clears itself. And it's not until they have blood drawn and realize they have actually had hepatitis. But one of the biggest problems is chronic hepatitis B. And we're going to talk a good bit about that later on, because there are complications from that. And there are lots of people with chronic hepatitis B in the United States who don't even know it. So just a little bit about the disease state hepatitis B. As I mentioned, it can cause both acute and chronic disease. Typically, the transmission is percutaneous or mucosal exposure to infectious blood or body fluids. Hep B is found abundantly in body fluids and can survive up to 7 or more days on fomites. What that means is particles that are on surfaces, such as computer screens or bedside tables or lab equipment. So the virus can actually live up to 7 days outside the body. You may not even see any visible blood, and hepatitis B can still be transmitted. And this is a little bit of a scary number, but hepatitis B is up to 100 times more transmissible than HIV. And so when we think about individuals working in healthcare centers, providing healthcare who get an accidental needle stick, the first thing we think about is HIV, but we really need to think about hepatitis B as well as a concern. The symptoms may be very vague. It may be just fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain. Once somebody develops jaundice, they have got significant inflammation of the liver going on. And I'm going to show you a picture of an individual with jaundice, and you'll recognize that. 50% of adults with acute infection do not experience any symptoms, as I mentioned earlier, and most people recover completely. So we're really not so worried about them, although we want to protect people from getting hepatitis at all. But it's the individuals who have chronic hepatitis B, have no idea they have it, and they are at risk of exposing other individuals. And we'll talk more about chronic infection in a little bit. Now, this is kind of fun. I call this the wheel of hepatitis transmission. And these are ways that hepatitis B can be transmitted. So I'm gonna start up here around 11 o'clock. So needle sticks, sharps, injuries on the jobs. Everybody thinks about that. You get jabbed with a needle. Do I need to be worked up for hepatitis B? Have I been vaccinated? That's pretty obvious. Unprotected sexual contact. Everybody's aware of that. The more unprotected sexual contact you have with the more partners, the more you're at risk. Sharing drugs, needles, or works such as cottons, cookers, or spoons. So injectable drug use. We're going to talk a little bit about how the opioid epidemic has impacted injectable drug use, and that has impacted hepatitis B and the rates in the United States. One of the saddest but best known methods of transmission is from a hepatitis B infected mother to her newborn baby. And so there are very definite protocols for how we handle that. Contact with blood or open sores of a hepatitis B infected person is a way it can be transmitted. Sharing personal care items such as razors or toothbrush. You may say toothbrush, but if somebody has a small amount of bleeding from their gums, somebody else uses that toothbrush and they have a small amount of bleeding from their gums, hepatitis B is very infectious and can be transmitted that way. Simply living in a household with an individual with chronic hepatitis B can expose someone and create greater risk of hepatitis B transmission. Using unsterilized needles in ear or body piercing, tattooing, or acupuncture, any of these facilities need to have good standards for sterilization and preventing transmission of infection. This one, as a pediatrician, I think is just fascinating because pre-chewing food for babies is not something that was at the top of my list. And I did a little bit of reading on this actually, and if you think about babies developing, nutritionally, when they get to be about 6 months old or so, they're ready for something more than just breast milk or formula. They need solid foods. But if you think about the number of teeth they have, It is not very many at 6 months. And so in a lot of societies, there's plenty of baby food, they're strained, they're processed. Mothers may make their own, they may grind it up in a food processor, but in some cultures that's not available. And so what happens is the mom or the dad, maybe, but it's usually the mom, will pre-chew the food for babies and then feed the baby the food that they have already chewed up. So it's basically you're making their own processed baby food. Well, again, back to the toothbrush story, if that individual has hepatitis B, they may not have good dental care, good dentition, they contaminate with blood, that goes into the baby's mouth. If the baby's teething, then that is a way of going right into the bloodstream. So that's actually a way that pre-chewing baby food or food for babies can transmit hepatitis B. And then when we're in medical settings, if there are not good infection control practices, such as using blood glucose monitoring tools, that's another way that hepatitis B can be transmitted. So there's the obvious ways we think of right off the bat, but then there's some more subtle ways that hepatitis B can be transmitted as well. So chronic Hep B. Hepatitis B by itself is not a huge problem, although it can be with liver dysfunction, that kind of thing. It's really these two complications that we're concerned about. 15% of cirrhosis cases are caused by hepatitis B virus. That is a significant percentage of cirrhosis. Still, number one cause of cirrhosis is alcohol. Then when we look at hepatocellular carcinomas, up to 50% may be caused by hepatitis B virus. And these are really the worst outcomes of hepatitis B, because both can end up in death eventually. There is no curative treatment for hepatitis B. And this is something that people sometimes get mixed up when we talk about the different hepatitis. There is a cure for hepatitis C. This has come about in the last 10 years or so. It works well. There's no cure for A, which is usually self-limited, and there's no cure for B, but we have vaccines for both hepatitis A and hepatitis B. So the key is not waiting until somebody gets hepatitis and trying to treat them with antivirals, because you're not gonna be able to cure them. It's preventing hepatitis B. And so you're gonna hear that message over and over in this talk today. We're here to think about how do we prevent hepatitis B. And these are some clinical pictures. When I mentioned jaundice, that's the yellow coloring you see in this person's skin and the eyes. The most common time I've ever seen jaundice is in newborn babies. There's a physiologic jaundice that babies get. Their eyes will be a little bit yellow, their skin will be yellow. In a newborn, that's usually not a sign for worry because they're going to clear it in a few days. But when you see an adult with this level of jaundice, that's a bad sign. This is a sick liver. Most of the times the liver is shiny and smooth on the surface. You can tell that this liver is diseased and cirrhotic and not doing well. And then this is a picture of someone with ascites and portal hypertension, which you can see these veins dilated. This is because the liver is so diseased, the portal vein has been obstructed and is causing this kind of picture we see here. So these are some of the scarier pictures of hepatitis B. So let's talk a little bit about the epidemiology and what's going on worldwide. So these data are from 1957 to 2013. And if you do a quick glance, the red areas are where the highest hepatitis B is in the world. You can see lots and lots in Africa and a fair amount in Asia. And then the pink color, there's still a lot. So there's a lot of hepatitis in Southeast Asia and China and that area. And then the yellow areas, which kind of vary, you see it in Russia and Northern Africa, and the light yellow in the United States and Canada. That doesn't mean there's no hepatitis. It means that the rate is fairly low compared to other countries. I'm going to share with you in just a minute what's going on in the United States, and it may concern you. You see that we're going in the wrong direction. So the impact of Hep B in the United States, there's an estimated over 20,000 new infections every year, which is about a 21% increase from 2014 to 2015. Most of this is in adults because for years we have had a policy of universal vaccination of newborns against hepatitis B. So babies, it's recommended they get their first dose in the hospital and they get subsequent doses as part of their infant immunization series. And we've done pretty well with that. So we have seen a big drop in pediatric cases of hepatitis B. So 95% of what we're seeing now is in adults. A scary number here is up to 2.2 million people in the United States live with chronic hepatitis B. And 2/3 of these people have no idea that they're infected with hepatitis B. And again, the two complications we worry about are cirrhosis and liver cancer, which end up in approximately 5,000 deaths per year related to hepatitis B. This is a problem and it is preventable. It is preventable if we vaccinate. Now, this is some more recent data from the CDC, and what each of these lines does is it looks at the cases per 100,000 over time. And so if you look at the 0 to 19-year-olds, you can see there's a little bit in 2002, but it's really come way down. I mean, there are very few cases in young children and adolescents. And then as we look at the other age groups, you can see most of those have come down, but there's two groups that have gone up. The green line, which is 40 to 49, and the blue line, which is 50 to 59. So these are individuals 40 to 60. What's happening? Why is it going up? It's going the wrong direction. And we're going to talk about opioid use and injectable drug use in just a minute, but that's the reason these two populations are going up. And we'll go to the next slide. So I'm going to give you some just kind of brief factoids on what certain states in the United States. Oregon's not on this map as far as highlighted, so that's a good thing. But if we look at Maine, for example, there was over 400% increase in new hepatitis B cases between 2011 and 2015, and this was related to injectable drug users. In addition, the Appalachian states, Kentucky, Tennessee, and West Virginia, between 2006 and 2013 saw a 17% increase in prescription opioid use. And what we know is that the more opioids that are prescribed, the more the population ends up using injectable drugs and then ends up acquiring more hepatitis B. And then Massachusetts, which you would not normally think of. I mean, a lot of people expect kind of in the West Virginia, Tennessee, Kentucky area that there might be more hepatitis. But in Massachusetts, there was a major outbreak in 2017, which was a 78% increase over the annual average. And 22 of the 32 cases were persons who were known to inject drugs, and most of those were adults. And North Carolina, where I live, also showed a 56% increase between 2014 and 2016. All these states are going the wrong direction, which then brings the whole United States going the wrong direction as well. And what we're seeing is a little bit of change in the demographics of who is starting to use injectable drugs. And this is a racial breakdown. And what you can see is that there's been a shift gradually, a smaller percentage of Black and Hispanic Latinos, and a larger percentage of whites are new people who are injecting drugs. So we're going to talk a little bit about serology. That's a good bit of epidemiology there. So I really want to highlight this because this was new and released this year. So there's a hepatitis B primary care work group who got together and established guidance for primary care providers who are taking care of individuals with hepatitis B in terms of what should you do? How do you follow them up? How do you take care of these individuals? And this was a multidisciplinary panel, including hepatologists, infectious disease, pharmacy, public health, primary care. And it was a collaboration between the National Task Force on Hep B, San Francisco Hep B Free, and the University of Washington National Hepatitis Training Center. And this will be in your handout that you can download, but this is a great website that has the complete set of guidance on there. And I'm going to give you a few of the highlights on there. One of the best things in here is guidance on how to interpret serology when you've ordered the hepatitis B panel on somebody. It's like, what do we do now? So I'm going to talk about that a little bit. So let's say you've got somebody coming in and you draw the basic hepatitis B panel. So hepatitis B surface antigen is one component. In addition, we check for hepatitis B surface antibody to the antigen and hepatitis B core antibody. So there's two sorts of antibodies and one antigen that we test for. If someone is tested and they come back hepatitis B surface antigen positive, they have hepatitis, period. That person has hepatitis. It may be acute, it may be chronic, you don't know yet. And so what you have to do is more evaluation, you have to do counseling, you have to get a history, you have to determine if treatment is needed, if they have to have hepatocellular carcinoma surveillance. If the individual is pregnant, then there's a whole perinatal Hep B management that's included in the guidelines that I just mentioned. Now, if they're hepatitis B surface antigen negative, I'm going to show you what the serology may mean on this next page. So if you look at this, so this is the Hep B surface antigen. This is the antibody to the core antigen, and this is the antibody to the surface antigen. And I'm going to start down here. If somebody is totally negative on all these things, they have never been vaccinated against hepatitis, they have never had hepatitis, that person is what we consider susceptible to having hepatitis. So vaccinate them, particularly if they're at high risk. We do not have a universal policy right now in the United States for vaccinating against hepatitis B, but particularly if you're dealing with somebody who happens to be a healthcare provider and they come across negative on all these, go ahead and vaccinate. That person should be vaccinated. Now, if they come back negative on surface antigen and antibody to core, and they're positive for antibody to surface antigen, that means they've been vaccinated and that they are immune from prior vaccination. You don't need to do anything. They're considered to be protected for life. There's nothing else that you need to do. I'm now going to skip up here. If somebody comes back antibody to hepatitis B core and antibodies to hepatitis B surface antigen, that means that they have had a prior infection, but that their immune system is controlling it. So they are not at risk for transmission. And then the top box up here, hepatitis B surface antigen, like I mentioned, if this is positive, they have hepatitis, and we need to do further workup to determine if it's acute or chronic. And I'm going to show you a couple slides on that. This middle box is a little bit of a question mark because it can mean more than one thing. So if somebody comes back just with antibody to hepatitis B core, they could have a prior infection or an occult infection. And so I'll share a little bit about what you do in that case. So if they come back with the core antibody positive, everything else is negative. If they're immunocompetent, probably they had a prior infection, and you can just follow them. If they're on immunosuppressive medications, there's a risk of reactivation. And if they're immunocompromised, they need further workup by getting a hepatitis B viral DNA, which is a measure of viral activity at that time. And so when we evaluate somebody who's hepatitis B surface antigen positive, this is the group that has hepatitis, you can see there's a lot of things we do, and it always starts with a complete history and physical, routine labs, but then there's specific labs such as hepatitis B Hep B E antigen and antibody to Hep B E antigen, hepatitis B DNA, like I mentioned, and you can see you check them for all the other hepatitis as well, and you check for HIV. And then there's a certain number of imaging studies are done. So this is all part of the workup for somebody who's antigen positive. And then how do you counsel them? There needs to be some sort of follow-up care. You cannot take somebody who's hepatitis B surface antigen positive and just say, have a good life, because you don't know what's going to happen with them. So they need to be followed up at a minimum of every 6 months. They need to be educated and counseled on the long-term implications of chronic Hep B. They need to provide that information to their medical providers because they need to be aware of that. You need to have a discussion about alcohol use. They need to be healthy. And this is true for everybody in general, but particularly if somebody is Hep B antigen positive. And then they need to be educated on how they may be a risk of transmitting Hep B to other people. And then additional counseling, and again, this is more detail. I'm not going to go into all of this. These are very specific, but it goes back to some of the ways that I mentioned that Hep B can be transmitted. And if they have cirrhosis, so you've measured liver functions and their liver is not doing okay, then they may need antiviral medication. And so again, the hepatitis B surface antigen is kind of the light that goes on that makes you move in these other directions, because you want to find out, is this acute, is this chronic, do they have cirrhosis? You need to screen them for hepatocellular carcinoma. So there's a lot involved when that happens. And you can see that the other tests will guide you in the management. Again, all of this information is in the guidance for primary care that I mentioned earlier. So I can't encourage you to use that as a reference. I can't over encourage you to use that, because it really is well done. So what about prevention? You know, that's what we really want to do, is prevent having to go through all those and have sick individuals and those kind of things. So the World Health Organization is committed to eliminating viral hepatitis by 2030. Now, based on some of the numbers I just showed you, we're not going to get there doing what we're doing right now. And so as we look at how we can possibly do that, number one on the list is immunization against hepatitis B. And you can see other parts of the strategy include prevention of mother-to-child transmission, blood and injection safety, prevention of transmission among persons who inject drugs, and testing and treatment. Number one is immunization. So we're going to talk a good bit about immunizations now. Most people in the United States follow the guidance of the CDC. And one of the committees that helps decide on what is recommended for vaccines is ACIP, which stands for the Advisory Committee on Immunization Practices. And this committee is made up of experts in the field of vaccines and infectious diseases, representing many, many different medical specialties and societies. And what I'm going to share with you now is their guidance on adult hepatitis B vaccination. As I mentioned earlier, we have universal recommendation for children. And so all our babies should be vaccinated now. This has been going on since '91. And so we have young adults well into their 20s who are vaccinated as babies. So we've got a whole group of young adults who are already protected. And so now we're thinking about who's at risk for hepatitis B and who needs to be vaccinated. So we, as I mentioned earlier, we don't have universal adult vaccination. And so what the CDC is recommending is based on whether they fall in one of these four buckets. And the first bucket is based on their medical diagnoses. So individuals with diabetes from 19 to 59 years of age need to be vaccinated for hepatitis B. Individuals with chronic liver disease, individuals with HIV, individuals with end-stage renal disease, including pre-dialysis, hemodialysis, and home dialysis patients. So those are some of the medical diagnoses that would make it recommended that somebody get vaccinated for hepatitis B. Based on their sexual history. So sexually active individuals who are not in long-term mutually monogamous relationships, patients who come in with any other STD should be vaccinated for hepatitis B if they have not been, MSM, and sexual partners of hepatitis B positive individuals. So based on their sexual exposure is the second bucket of recommended groups. The third bucket, and some of you folks on this webinar may fall in this group, is your occupational risk. Persons who have occupational risk of infection, including healthcare and public safety workers. So anybody working in healthcare, and this is just not doctors and nurses and respiratory therapists, this may be the individuals who are changing housekeeping and changing out rooms from patient to another patient, because unfortunately sometimes sharps get left behind, they don't end up where they should be. And so you can't always control 100% for those kind of things. But if everybody were vaccinated who's working in healthcare, the risk would be really, really low. International travelers, and that's not exactly an occupation, it may be a hobby or for vacation, but depending on the country where the person is visiting, and think back to the map of the world I showed you, if somebody's traveling to one of the red countries, they need to be vaccinated for hepatitis B because there's a lot of it in that country and they need to be protected. And one thing, this is actually an OSHA requirement, is that if an employer has a job situation where they're putting people at risk for exposure to hepatitis B, they must offer immunization at no cost. And that's public safety workers and healthcare workers. So public safety like policemen, firemen, those sorts of folks. And then other risk factors, and this is kind of a big bucket. This is just the other category. Current or recent injectable drug users. This is an important group and a very difficult group to vaccinate. Household contacts of hepatitis B positive individuals. And this bullet, I think, is one of the most interesting ones on the slide. All patients seeking protection from Hep B virus infection. Now, who would do that? Who would just come up and say, you know, I just think I'm going to come in and get protected against hepatitis B? Well, perhaps they fall in one of these other buckets, particularly this one, but they don't really want to share that with you. So I actually think it was very wise of the ACIP to say, okay, we're not going to make somebody come up with why they're at high risk. Simply coming in and saying, you know, I think I need to protect against hepatitis B is enough of a reason to vaccinate that individual. And effective vaccination is critical to reducing the spread of hepatitis B. Healthcare professionals. Like I mentioned, this is a group that needs to be vaccinated. These are some scary and almost hard to believe numbers. Healthcare providers sustain up to 800,000 needle stick and splashes every year that can expose them to infection. So even with all the safe sharps and everything we're doing now, there's still a risk that they're going to get, someone may be exposed. The risk of hepatitis B infection, depending on the level of infectivity of the person that the blood came from, can be as high as 62%. And the blood may not be visible. Like I mentioned, it could be surgical and other healthcare tools, counters and surfaces, papers, medication vials if they're shared in a dialysis unit. And this is, so first of all, we got a lot of needle sticks and splashes, 800,000 a year. Transmission can be very high rate. And despite the high risk for HCPs, exposures often go unreported. And in one study of interns, fellows, and residents, 46% of percutaneous exposures are not reported. Even though there are protocols for post-exposure, what you're supposed to do, particularly physicians in training tended not to report it. It was a hassle. They were embarrassed. It took too much time out of their work schedule. There's a lot of different reasons, but this is a problem that if people are being exposed and they're not reporting it, those people are at higher risk for developing hepatitis B. Okay, now what we also know, and I mentioned who should be vaccinated for hepatitis B, there are groups that don't respond as well to the vaccines. And so when we look at factors such as age, being over 40, having a BMI over 25, smokers, men, certain chronic diseases that are immunosuppressive, and then over 60 increases risk, all of these factors have a relative risk greater than 1, which means that they put that individual at a higher risk not to respond to the Hep B vaccination. And so this is a problem that even when people get vaccinated, they may not respond well to the series. And then they may not get the whole series. So these are actually multiple studies, Nelson, Gunn, Trantham, Bridges, and Brooksford, looking at the percentage of people who start the 3-dose hepatitis B series. And just as a reminder, a refresher, dose 1 is given, dose 2 is given a month later, and dose 3 is given 6 months later. It's that dose 3 that people have trouble remembering. Compliance is low, they don't come back in, they're not hearing anything about hepatitis B, they don't feel a sense of urgency, and so that's a real challenge. This is the most recent data that was published that came out of Kaiser of Southern California, and only 26% of the people in the Kaiser system of Southern Cal completed the 3-dose series after they'd started it. This was published last year. In head-to-head trials, clinical trials, I'm going to show you some of those. 100% of the people finish because they're in a trial. That's part of what they're doing. But you can see these other studies looking at various populations, anywhere from 22% as a low to 54%. So we're not doing well with completing the 3-dose series. And then in addition, some of the high-risk groups that are recommended to be vaccinated are even worse about completing it. In healthcare workers, these are the completion rates. Only 74% of healthcare workers over 19 years of age completed the 3-dose series. And you'd think that, how could they do that? This is part of their job. They have to be vaccinated. Well, a quarter of them didn't. In the 19 to 59-year-old diabetics, only 24% completed it, and over 19, looking at the other high-risk populations over 19 years of age, only 34% completed the 3-dose series. So we're just not doing well. We can improve on what we're doing in terms of completion rates and who's responding. And then this is an analysis based on payer, and this is the percentage of individuals who complete the series. In a commercial plan, 39.6% complete the series, and in Medicaid, the completion rate is even lower at 24%. So none of these numbers are where we should be. This is actually some detail from the Bridges study that I showed you was on the bar graph a little while ago, looking at a variety of public health facilities where high-risk people get care, such as the Department of Corrections, STD clinics, federally qualified health center, drug treatment facilities. As I'm reading these off, you can be thinking, well, these are kind of the ones that were recommended to be vaccinated. This was a study where the CDC gave grant money to a number of different states and said, we want you to vaccinate these people with the 3-dose vaccine. So these are the numbers of people in each of these facilities who started the study, received dose 1, so 29,000. And then these are the numbers who completed the 3-dose series. And you can see that the percentages are low. And when we look at the overall, only 22.3% of the individuals completed the 3-dose series. And these are some of the highest risk individuals out there. So we have a problem completing the 3-dose series. And I know you're thinking, okay, you've said this 5 times. It's really an important takeaway. What we're doing currently conceptually may be good, but if people aren't completing the series, they're not going to be protected. So let's talk a little bit about vaccines overall. So when we talk about antigens and antibodies, an antigen is a molecule that's capable of stimulating an immune response in the body. It's something foreign to the body, enters the body, and then the body develops antibodies to that. And these are Y-shaped proteins produced by the B cells in the immune system. Passive immunity is where someone is given antibodies that they did not develop, their own body did not develop. Breast milk is a great example of that. Immuneglobulin, such as hepatitis B immuneglobulin, is antibodies are already there. You're giving it to that individual. You are not depending on their immune system to develop that. And this is kind of like your basic immunology 101. Then active immunity is when they are given a vaccine or a foreign substance, or we get sick, you get chickenpox, and you develop antibodies to that. That is active immunity when the individual's own immune system develops a response. So that's what vaccines are about, is triggering the active immunity component of the immune system. So how do we define protection? So there are numbers that will say you're either protected or you're not. And these are examples with all the various vaccines we give. And I want to draw your attention to hepatitis B and this 10 milli-international units per milliliter. That is the number that we want to achieve to feel that someone is protected. And this is actually based on a long-term study done in children in Gambia. And they found if they achieved a 10 milli-international units per milliliter level of antibody, they did not develop hepatitis B. So some of you may have been vaccinated for hepatitis B, and if you're in healthcare, you had to have your antibody levels checked. And typically they'll say, if you're 10 or greater, you're protected. If not, we've got to give you more doses. And so that's when we talk about seroprotection, that is the number that we're shooting for. And so I mentioned this for hepatitis B vaccination, hepatitis B antibody level 10 or greater. And when do you check that? You typically check it 1 or 2 months following vaccination, and it is a correlate of protection. It's not actually a reduction in the cases in hepatitis. You can't really measure that in a clinical trial. So we use this antibody level as a correlate of protection. And I mentioned the Gambian children earlier. It's important to remember antibody decay or decline. So let's say somebody comes in and gets vaccinated, they complete the 3-dose series, 2 months later, their antibody level is 50. Well, they may come back 2 years later and their antibody level is 8. So that's antibody decay. We expect it to drop off. Different people, different factors cause it to drop at different levels. The current thinking is that the individual who was 50, who's proven immune response and is now 8, does not need to be revaccinated. Now, there's a bigger challenge when we have healthcare workers, somebody who's just graduated or starting medical school or nursing school, and they were vaccinated as infants, because we don't check babies after they've been vaccinated. So we don't really know who's responding and who's not. We do know that infants generally respond very well to the vaccine. So when we test, you should test 1 to 2 months following the last dose. If the antibody is less than 10, you should revaccinate. If they complete a whole second series and they're still less than 10, they need to be checked to make sure they don't actually have hepatitis. So their hepatitis B surface antigen needs to be checked. And if that's negative, that individual is considered a non-responder. And there are just people out there. One of the nurses in my office just never responded. She took 3 complete series, and for whatever reason, she was a healthy young woman. She never generated an adequate immune response. So who gets tested? Like I said, we don't test babies, but healthcare workers, public safety workers, chronic hemodialysis patients, HIV-infected persons, other immunocompromised individuals, sex partners of hepatitis B surface antigen positive persons. It is not recommended for routine adult vaccination. So all these other populations that were in the 4 buckets I shared with you, not all of those need to be checked after they're vaccinated. But in clinical trials, everyone is tested. Okay, so I just want to mention what is I'm looking at my time here. Okay, we're good. So what is a challenge dose of a vaccine? So let's say that an individual has a history of vaccination. Maybe they're vaccinated as a baby. They come in, they're starting to work at your hospital. You draw on their antibodies less than 10. Then you can give them what's called a challenge dose, which was 1, because we never knew if they responded. You give them 1 dose, and then you measure antibodies a month later and see what it is. If it jumps up over 10 at that point, that's somebody who is immune. It's just that they were never tested when they were younger, so you didn't know that for sure. So that's what a challenge dose is. And a lot of this information about who should get dosed, what is a challenge dose, those kind of things, you can find at cdc.gov and look under guidance for hepatitis B vaccination. It's a great resource. I did want to mention what hepatitis B immunoglobulin is. When I was talking about active immunity and passive immunity, this is passive hepatitis B immunity. So this comes from human plasma that has high levels of antibodies to Hep B in there. It's considered passive immunity. It's temporary. You give a dose, it's an injection, and it only lasts for a few months. But we typically give it if somebody is unknown, they get stuck with a needle and the individual has hepatitis B. You can see these other categories: victims of sexual assault, people who have unprotected sex with a person with Hep B, newborns and infants less than 12 months of age whose mothers have Hep B, and also newborns after they're delivered if the mother is at high risk. So there's a lot of reasons we use HBIG. One of the challenges is it's very expensive. And so the more people we can vaccinate with the vaccine, the less HBIG we will need to use as we move forward. And there are highly immunogenic hepatitis B antigen vaccines that induce immunity by generating antibodies and prolonged immune memory. which provides continuous protection, not only antibodies, but cellular immunity as well. I'm not going to go through all the information on that. Now, what's an adjuvant? So when we talk about a vaccine, what's in a hepatitis B vaccine is Hep B antigen, a small amount of that, not enough to cause anybody disease because you have to have the whole virus. There's just a little piece of the surface. But in addition to that, there's an adjuvant, which is, you can think of it as an enhancer or a booster in generating an immune response when you're vaccinating an individual. And this has a little more detail on that, but it tends to increase the percentage of individuals who get protectively immunized, increases seroconversion. It allows for a much smaller dose of antigen, and it permits immunization with fewer doses. So adjuvants help generate a good immune response in a vaccine. When we look at historical vaccines, the number one adjuvant used is aluminum, and there's a number of different aluminum salts that are used. The one in Hep B, the 3-dose series, is alum, which has been used for decades. Alum generates a broad range immune response, broad range of cells, causes cellular disruptions, but there's not a specific receptor for alum. In the newer 2-dose hepatitis B vaccine, and this is something we'll talk about a little bit. So the 3-dose vaccine has been around for decades. The 2-dose has been around since 2017. The novel CpG adjuvant actually targets a single immune receptor called a toll-like receptor 9, which is important in triggering a robust immune response. And I'm going to show you a picture of that. I'm actually not. And what that does is it hits the dendritic cell, generates higher levels of antibodies, and then also cellular immunity. Then, okay, so what's available out there? When we look at vaccines that are recommended for adults, these are some of the ones for adults 19 and older. For hepatitis B, 2 or 3 doses depending on the vaccine. So those are your 2 options. And the ones that are approved for single antigen vaccine, and that means just for hepatitis B, as opposed to a combination vaccine, which is hepatitis B and other antigens like Twinrix, which is hepatitis A, or Pediarix, which is multiple antigens used in children. We're just going to focus on single antigen. So there's 3 manufactured now. Recombavax, which is a single dose given over 6 months, 3 times. Engerix B, which is also a 3-dose series, and Heplisav, which is a 2-dose series over 1 month. And what I'm going to share with you is some of the clinical trials comparing the 2-dose and the 3-dose vaccine series. So there are actually 3 trials, trial 1, trial 2, and trial 3. This is younger adults, 18 to 55, older adults, 40 to 70, and a broad range of ages, 18 to 70, but with an emphasis on safety and diabetics. So looking at people that tend to be at higher risk, and as I mentioned earlier, diabetics tend not to respond as well to the vaccine series. And what I'm going to share with you is just a little data from the 3 trials. When we talk about seroprotection rate, this is the percentage of people in the study who achieved 10 or greater. So at the beginning of the study, nobody had antibodies. So we measured the antibodies. It was 0 in everybody. If they had antibodies, they'd either had protection or they'd had the disease. So everybody was naive. On day 0, they were given a 1 dose of either the 2-dose vaccine or the 3-dose vaccine. They came in a month later for their 2nd doses, and antibodies were measured at that time. For the 3-dose vaccine, what was seen in this population was 4% of people had seroprotection at that point after a single dose. You don't expect that. It's a 3-dose series. A month after the 2nd dose, about 26% actually had seroprotection. Again, it's a 3-dose series, so we don't expect everybody to be protected. And then they got the 3rd dose here of Engerix versus a placebo in the 2-dose group. And the following month, they were up over 80% seroprotection rate, which means that 81.1% of the individuals in this trial achieve seroprotection of 10 or greater after completion of the 3-dose series. In contrast to that, again, everybody in the blue line is the 2-dose. After a single dose, 23% of the individuals had seroprotection, and a month after the second dose, over 88% had seroprotection. You can see then it extended out up well above 95% in this group. And what we know is the younger, healthier subjects tend to respond better to vaccines. As we get older, we get immunosenescence and we don't respond as well. So this trial was specifically looking at older people, and probably a lot of us on this call are in this age group, so I hate using that older, but that's what the idea was. Same thing here. This is the seroprotection rate. If everybody was seroprotected, it'd be 100%, 0 if nobody. The gray line is the 3-dose vaccine, and you can see the numbers are still low after 1 dose and 2 doses, and it's not until after the 3rd dose that we got up as over 72% in this particular study. In contrast to that, the 2-dose vaccine, get dose 1, dose 2, the following month you're over 76%, and then up over 90 for the duration of the study. So this is even in the older, slightly harder to vaccinate population. And then the last study I would just want to mention is trial 3, which was looking at people that are harder to vaccinate. Diabetics, looking at the age breakdown, men versus women, obese, and smokers. If the results were exactly the same in the Injurix and the 3-dose and 2-dose vaccine trials, these dots would be on 0. Everywhere the 2-dose vaccine showed superiority to the 3-dose vaccine, the dots are to the right of the 0 line. And you can see that every one of these breakdowns favors hepatitis B CpG, which is the 2-dose vaccine. I want to particularly draw your attention to diabetics because, again, this is a high-risk group. It's recommended they get vaccinated, and we know they don't respond as well. And in this study, the rate of response was very high. And then this is looking at all 3 of the trials, just kind of the summary seroprotection rate. The blue is the 2-dose vaccine, the dark gray is the 3-dose vaccine, and you can see there was a significant difference in seroprotection in all 3 studies. And then in safety, this is looking at the 3 studies. The unsolicited adverse events were similar in both groups, both the 3-dose and 2-dose series. Serious adverse events were similar, and immune-mediated adverse events were similar in the 3 trials. So just kind of a few summary points. As many as 2.2 million, that's a big number, keep that in your mind, in the United States are infected with hepatitis B, and the rates are going the wrong way. That's a big take home. The second thing is the CDC provides guidance on high-risk groups to receive hepatitis B vaccine. So when you're in doubt, you're not sure if somebody should be vaccinated, the CDC is a great resource. And the concern with the 3-dose hepatitis B vaccine is that they may leave many adults unprotected or at risk, either because they don't complete the series, as we saw, compliance is an issue, they did not achieve seroprotection, or perhaps they had some sort of underlying disorder that made them not respond as well to the vaccine. And with that, we'll go to questions. And I don't know how we're doing on time. We got a few minutes for questions. So Carmen?
Thank you, Dr. Walker. So let's see. Let's start with questions. Please use your question menu on your control panel at the bottom and go ahead, ask any question. So I think everybody understood everything. I'm not seeing any questions.
It was too much information. I know what it was.
I think, no, you are a great presenter, so everything looks like everybody understood everything. Okay, so what we can do is if you have questions and something comes up to you during, oh, there's one question. Fantastic. Let's see. what is the cost difference between the 2-dose and 3-dose?
So keep in mind that there's a difference in the number of doses. So the 2-dose is more expensive than the 3-dose, but when you consider that you're just using 2 versus 3 doses and the actual percentage seroprotected, and our sales guys actually handle most of the sales, the cost numbers. It actually shows that you're protecting more people for the same number of dollars by using the 2-dose series than you are using the 3.
All right, thank you. Did I hear there was a single dose?
Not that I've heard. Yeah, the only time you use a single dose is as a challenge dose, so that somebody has a history of being vaccinated. You don't know if they responded way back when they were a baby, and they're starting work in your hospital. You may want to, and they don't have any antibodies, you may want to give them a challenge dose then. But as far as I know, there is no single dose hepatitis B vaccine.
Thanks. There's another question. I'm concerned that many of the at-risk population are not insured.
And that's a problem in general. And one of the things that's going on is there is a lot of government support, for example, at needle exchange clinics for people who use injectable drugs. A lot of times vaccines can be provided at those types of facilities and clinics. STD clinics many times can vaccinate individuals, and there are ways to get government supported vaccine. Again, I don't get into a lot of the details on what the costs are, but many times those can be granted so that the certain number of dollars can be used to buy vaccines for those patients.
All right. Thank you. Right now we're getting comments. Nice presentation. Thank you.
Thank you. Thanks for dialing in.
So, okay. I think that's for the questions today. That's it. So let's go over and repeat the housekeeping information. Thanks for participating today. To help us provide best future training events, please take a moment to complete the survey that will appear as soon as the webinar ends. We will email you the link to our website and the recording of the webinar by next week. And feel free to reach out to me or our office if you have any questions or concerns. We'll be happy to be of assistance. As we added on our flyer, this webinar does not provide CME or CE credit, but we can provide you a certificate of assistance. So if you would like one of those, please send me an email. I'll get that one for you. And so with that, you have now completed the hepatitis B webinar and you may disconnect. Have a wonderful day. Thank you, Dr. Walker.
Thanks, everybody.
Goodbye.